The next presentation is large fenestrations versus scallops for the SMA during fenestrated EVAR. Does it matter? By Dr. Saronda and colleagues from Stanford.
Good morning, and thank you for the opportunity to present. We have no relevant financial disclosures. First described in 1999, fenestrated endovascular aneurysm repair uses customized, patient-specific endovascular devices to treat juxtarenal aneurysms, allowing for the ability to place stent grafts in the aorta at and above the renal arteries. The use of fenestrated devices has steadily increased over the past 2 decades, and the Cook-Z-Fen device was first approved by the FDA in 2012, making fenestrated devices more readily available in the U.S. It has been approved for the treatment of patients with short infrarenal neck lengths greater than 4 millimeters and less than 15 millimeters. The Z-Fen configuration allows for a total of 3 fenestrations, only 2 of which can be the same. The most commonly built configuration is 2 small fenestrations for the renal arteries, followed either by a scallop or a large fenestration for the SMA. A scallop is a U-shaped cutout from the proximal edge of the graft that is strut-free, thus allows the SMA to be stented in the case of stent graft misalignment during deployment. Because the scallop does not provide circumferential seal, the effective seal zone is limited to below the SMA orifice. A large fenestration is a circular opening from the graft. It can be placed at least 10 millimeters from the edge of the fabric, allowing for greater SMA seal zone length. Large fenestrations have struts crossing at the edge or the middle of the fenestration, which limits the ability to place alignment stents. Again, small fenestrations are most commonly used for the renal arteries. SMA configuration is decided upon preoperative patient anatomy. Short distance between the renal artery and the SMA stenosis, as well as a tortuous aorta, are indications where a scallop may be better suited in case of intraoperative fenestration misalignment and the desire to preserve the option to stent into the SMA. Indications for a large fenestration include the need for more proximal seal zone, such as a juxtarenal aneurysm. Clinically significant outcomes comparing SMA scallops to large fenestrations with the available Z-Fen device are lacking. We sought to compare clinical outcomes and sac regression of patients treated with the commercial Z-Fen between the 2 SMA configurations. We retrospectively reviewed our prospectively maintained database for all Cook-Z-Fen patients undergoing either a scallop or a large fenestration. All first post-op CT scans within 1 to 30 days were measured for proximal seal zone lengths. This was defined as the start of the fabric to the start of the aneurysm for large fenestrations, and the start of the base of the scallop to the start of the aneurysm for scallops. Here's an example of how we measured proximal seal zones using TerraRecon. For scallops, we measured from the start of the fabric to the aneurysm, then looked back at our configurations and subtracted the distance from the total measurement. A total of 234 consecutive Z-Fen patients from 2012 to 2021 were reviewed, and 137 of those either underwent a scallop or large fenestration with imaging available for analysis. So we had a total of 72 scallops and 65 large fenestrations. Mean follow-up time was 35 months. Amongst our cohort, the average age of patients was 73.7 years, and a majority were male. Differences existed between baseline creatinine and CKD, both of which were higher in the scallop group. Infrarenal neck diameter, suprarenal neck angle, and device diameter also differed significantly. A potential explanation for the difference in neck angulation is the preferential use of a scallop in a more tortuous aorta, again, to allow for the ability to place a stent if need be. With regards to perioperative outcomes, our operative metrics are similar, other than a slightly higher contrast volume in the large fenestration group. Mean proximal seal zone length was 19.5 millimeters for scallops on average and 41.7 millimeters for large fenestrations, which was significantly different. Overall 30-day mortality and all-cause 3-year mortality were not significantly different. Additionally, there was no difference in sac regression between the 2 groups at 1 year. In this figure, stack regression is listed on the y-axis, which shows that a majority of patients showed some degree of stack regression at 1 year. Those with stack expansion were mostly due to type 2 endoleaks. There were no type 1A endoleaks that required any proximal neck reinterventions in this group. Listed on the x-axis is seal zone length, showing that the scallop configuration on average led to seal zones 15 to 25 millimeters, and large fenestrations led to seal zones typically between 25 and 45. We also performed a logistic regression analysis to account for significant differences between the two SMA configurations and determine their influence on stack regression. As you can see from these p-values, stack regression was not significantly modulated by other differences that existed in this population. Listed here are our total early reintervention rates. As you can see, we did have one patient that had shuttering of the SMA scallop that eventually underwent a covered stent. The rest of these interventions were all repaired successfully, mostly with endovascular techniques. Limitations to the study include a small sample size based on reinterventions, therefore underpowered to detect differences on reinterventions. However, it is one of the largest studies to date of ZFENs comparing scallops to large fenestrations. In any large data set, there will be some missing CT scans. In our cohort, we had a total of 19. And lastly, this was performed at a high academic institution with the resources available to perform these complex endovascular cases, as well as a white male population that may not be generalizable to other areas. In conclusion, despite longer seal lengths, large SMA fenestrations were not associated with a difference in stack regression compared to scallops. There were no differences in reinterventions or overall long-term mortality between the two SMA configurations. Selection of configuration for the SMA should be decided based on preoperative assessment of patient anatomy to assure an adequate seal length. And further studies are warranted to further delineate clinical outcomes and determine the optimal seal zone length. This concludes my presentation, and I now invite any questions at this time. Thank you.
Thank you for that presentation. The question I have has to do with the anatomy of the actual aneurysm. You said that you selected whether you were doing a scallop or a large fenestration, usually based off of the anatomy of the aneurysm. Is there any way to control for that? And basically, what I'm asking is, if you use the scallop for the wrong "quote unquote" anatomy, would you have no difference in outcomes?
That's a great question. What do you mean, like, for the wrong anatomy?
Well, you mentioned there were some specific anatomical criteria that you would tend to use a scallop for.
Okay.
So what would happen if you used a large fenestration?
We didn't really look at that and account for that. I think.
Because basically, what I'm saying is that you're assuming that people are selecting a large fenestration or a scallop for the correct reasons.
Yes, that's true.
Okay.
Hey, Greg McGee from USC. Very nicely presented. Excellent work, as usual, from your group. So my question was similar about the underlying reasons for choosing one versus the other configuration. Obviously, your group has a lot of experience with this and makes a decision about which one to use in which situation. And perhaps large fen versus scallop is actually just a proxy for what the anatomy is. I think that's maybe what Matt was talking about. The other thing is that my bias is that more seal zone is probably better than less seal zone, and we know this is true from the infrarenal aorta. So you did find that there was 3 times more reinterventions for the proximal neck in the scallop arm than in the large fen arm, which was also associated with less seal zone. And that was associated with a 2x higher mortality. Now, granted, you didn't find that was statistically significant, but that's really because the study is underpowered to look for that. So my question is, does that impact your decision now in the future to use scallops versus fens? And then, obviously, the reinterventions, as you mentioned, can be more challenging with large fens. So how does that all factor into it? Thanks.
So to address the proximal neck reinterventions, I know that's listed in the abstract, but once we accounted for any patient that did have additional procedures, such as like a chimney or snorkel, If you look at just our cohort with the classic 3 fenestrations, we did not have any proximal neck reinterventions at all in our cohort, if that answers your question.
No, thanks, Greg, for the question. I think the reason why we wanted to look at this really was whether you always have to build a large fen or not. Generally, I think folks do sort of agree the longer seal zone is better. And I think when we thought that we had seen a large number of scallop patients do fine with very good sac regression, and I think the key figure is the one with the Y and the x-axis plotting out. Most of the scallops wind up having a seal zone around 15 to 25. Most of the large fen wind up having a seal zone 25 to 45. And honestly, we were surprised that there weren't more proximal neck dilations, proximal neck reinterventions. The reintervention question, most of the things, if you looked at it, were actually renal issues, distal aortic issues, limb occlusion. I don't think those are affected by whether you put a scallop or a large fen. And I think you did bring up a good point. If you always put a large fen, you do have some slight limitations in the future should there be an issue more proximally because of the struts that go across a large fen.
Yeah, that was a great study. One of the things that we've noted in our series is that with physician modified, the seal zone is effectively 4 centimeters greater every time, and the reintervention rates are really low over a long period of time. You looked at 1-year SAC regression. It'd probably be good to look at longer-term outcomes in these patients too, because one year may be fine, but you want to look at these people 3 years down and 5 years down and see what happens. So it'd be great to keep this data going, but it's a really nice presentation.
Thank you. That's an excellent point, and I'm excited to present this in 5 years to see if we have any updates.
Great. Thank you. All right,